Hi, everyone. Come on in. Come on in. Welcome to the session on patient preferences and decision quality. My name is Holly Witteman. I'm an associate professor at Université Laval in Quebec City, Canada, and I'm a trustee with SMDM. I've been coming to these meetings for a really long time, and it's always such a pleasure to see the great work that people are doing. I'm going to let my co-moderator, Beverly Cannon, introduce herself. You've got a mic there.
I thought you were going to do it for me.
Oh, sorry.
I'm Beverly Cannon, patient stakeholder engagement coordinator here this year. Last year was privileged to be a co-chair of the SMDM meeting.
So for those, everyone's been going to sessions so far today, so I'll just remind you of the basics, which is that everyone gets 15 minutes. We're already cutting into it, so I'm going to stop now. And try to keep your questions short if you can, and you are welcome to move between rooms. So our first speaker is Semra Ozdemir, who's going to speak about discordance in decision-making and its association with psychological distress and perceived quality of care in advanced cancer patients.
Thank you, Oli. Disclosures first, the study was funded by Singapore Millennium Foundation and Lian Center for Palliative Care in Singapore. Can you hear me, by the way? Okay, great. And my authors don't have any conflicts of interest. Well, I don't need to really talk about shared decision-making in this room, but what I want to talk about is the applications of shared decision-making in Asian societies, collectivist societies, may not be as straightforward. Most research in shared decision-making has so far, I want to emphasize most, has so far focused on the patient-physician diet. However, for Asian societies, we're missing an important stakeholder, which is the family caregivers. Families are an important part of everyday life decision-making as well as decisions made in healthcare. So there are many reasons for that, but I want to emphasize a philosophy, filial piety in Chinese societies. So according to this philosophy, elderly patients especially expect their elderly individuals, as individuals, not just patients, they expect their families, their children, adult children, to take care of them. And elderly children sees as their duty, responsibility to take care of their elderly parents. So this gives a completely different perspective in the decision-making process because family caregivers are very involved. Sometimes they're the main decision makers in healthcare decisions. In this case, is the question really about active participation? Because some patients may be very happy to leave the decisions to their families. They actually expect their families to make these decisions and take care of them. So in this spirit, my question is maybe we should really focus on not the active participation, but whether patients participate in decision making as much as or as little as they want. So whether they involve at their desired level. So I looked at discordance between patients' perceived and preferred roles in decision making. Perceived is as how they perceive their experience was in terms of decision making, and then their preferred roles. And we looked at the triad, like patient, physician, and caregiver triad, how patients reported the roles for these three different stakeholders. And I also investigated how this discordance is associated with psychological distress and perceived quality of care. So my hypothesis is that patients who report discordance between perceived and preferred roles in decision-making will also report higher anxiety, higher depressive symptoms, as well as poorer perceived quality of care. Then the question is also, okay, does the type of discordance matters? Because you can imagine discordance can be in two ways. They may involve more than they wanted, or they may involve less than they wanted. So in this case, my hypothesis is that patients who report to being involved at a lesser level than they wanted will be worse off. They will report worse outcomes compared to other types of patients who reported other types of discordance or concordance. And the reason is that these patients who couldn't enroll at a level that they wanted are more likely to not being able to raise their questions, have unanswered questions, and even be more likely to end up on treatments that were not aligned with their preferences. So this data comes from a cohort survey, but the data actually is the data I'm going to share with you is from the baseline survey from a cohort data that we conducted with 600 advanced cancer patients in Singapore. So these are all adult patients, 21 and above. We recruited them from outpatient oncology clinics from the two largest hospitals in Singapore, and they're all diagnosed with stage 4 solid cancer. So here are the questions I used. These are questions adapted from the famous CANCOR study, which was done in the US with advanced cancer patients. So what the CANCOR study did was they asked the decision roles between the patient and physician diet, and then they had a separate set of questions looking at family involvement. So what I did, I combined it so that I can look at these roles for the triad, patients, families, and the doctors. So as you can imagine, this involvement of 3 different stakeholders can be really complicated. So I did a 2-step format. In the first question, I asked who were involved, so they could check as many as they wanted. And then the second question asked the specific roles each stakeholder played. So the first set of questions asked the perceived role, how they experience, and the second set of questions asked their preferred roles in decision making. So I define the discordance as any discordance between the preferred and perceived roles in decision making, and the type of discordance can be 2. The 2 of them I mentioned to you involving less or more, and the third category is actually no change in patient involvement, because the involvement of the other stakeholders, physician or family, may change, but not the patient. So I did 2 types of analysis, univariate and multivariate regressions. In the univariate regression, the interest of my main interest of the independent variable of interest was a dummy variable indicating the discordance between the perceived and preferred roles. In the multivariate regressions, I have the same dummy variable as well as another indicator that I was interested in. That was the interaction effects between the discordance dummy variable and another dummy variable indicating being involved at a lesser level than preferred. So this was the test, whether the type of discordance matters. In the multivariable regressions, I also controlled for patient characteristics and patient health history. And the dependent variables were psychological distress. To measure psychological distress, I used hospital anxiety and depression scale, HEDS. So I had anxiety separately, depression separately, as well as a total score for psychological distress, and I ran separate regression analysis. And then I looked at also perceived quality of care. So perceived quality of care, these questions were also taken from CANCORs. There were actually 3 domains, but I used the 2 domains that were really related to decision making. The first one is the quality of physician communication. The second one is the quality of care coordination and responsiveness. For health history, I had symptom burden and then cancer type. Patient characteristics are the usual suspects. So in terms of patient characteristics, we had 600 patients, but 1 patient didn't answer the decision-making role question, so I had to drop that patient, so I ended up with 599 patients. So the mean age is 60, about half is male. Most of the patients are Chinese and married, and they have, most of them have high school diploma or below, so these are individuals with lower education. And the most common cancer types were lung and colorectal and gastrointestinal cancer. Okay, so in terms of discordance, what I found was that only 16 percent of patients reported discordance between perceived and preferred roles. And when we look at the types of discordance, 1/3 reported being involved less than preferred, about half involved more than preferred, and 20% was no change in the patient involvement. So let's look at the univariable regression analysis that look at the association. And so what I found that patients who reported discordance also reported greater anxiety, poorer physician communication, and poorer care coordination. So depression wasn't significant, so I didn't include here. And when we look at the multivariable analysis, after controlling patient characteristics, discordance was not significant anymore, but the interaction effects were. So patients who were involved at a lesser level than they preferred reported poorer physician communication and poorer care coordination. Anxiety and depression was not significant. These were, of course, compared to those who reported other types of discordance and concordance. So limitations of the study, of course, we're looking at only associations. We can talk about causality because this is coming from a survey, cross-section survey data. I'm suspecting some underreporting of discordance because we ask the preferred roles right after the perceived roles. So patients may be more likely to say, oh, okay, that was how I did it and how I prefer. And then, of course, there might be reverse causality between perceived quality of care, anxiety, depression, and discordance. But in conclusion, actually, I must say I was very pleased to see that discordance was reported only by 16% of the patients. So current clinical practice seems to be giving opportunity to patients to involve in as much as they wanted. However, this doesn't mean that, even then, patients may not want to involve as that much. Physicians should still inform them about their treatment options and patients should still approve the selected treatment path for them. However, since what we are seeing is it's not the discordance, it's the involvement at a lesser level than preferred is associated with poor outcomes, it might be safe to encourage patient involvement in decision making. Thank you very much.
Thank you. We have time for 1 or 2 questions.
Hans Stukkelbout, Leiden, the Netherlands. Thank you. That's an interesting study. I was wondering, since about half were more involved than they wanted, and it's the Chinese population mostly where there's not an individualist society,
Yes.
why you had the hypothesis that being less involved than they wanted would create more stress, and whether you analyzed also what happened to those 47% that were more involved than they wanted, because the comparator was the large group of concordant, I assume. So it could still be possible that those who were more involved than they wanted also could be distressed. No?
Actually, sorry, I had to go through really fast. So my hypothesis was that discordance would be associated with these poor outcomes, but within the discordance, those who involve less than they prefer would be even worse off. So for me, involving less or more, both will be associated worse outcomes. But that was my hypothesis. But what I'm showing is that if we just look at discordance, yes, it was positively associated significantly associated with these outcomes. However, the driving force was really involving those who involved less than they preferred. So that was really the driving force for the poor association with poor outcomes.
Thank you.
Thank you.
Yeah, thanks.
Our next presenter is Karen Sepulka, who will speak on measuring the quality of decisions for elective orthopedic procedures across a large healthcare system.
Did someone move? Oh, sorry.
Great. Thank you very much. So just by way of disclosures, the research was funded by a grant from the Patrick and Catherine Weldon Donahue Foundation, but no other authors have any conflicts of interest to report that are relevant for this work. So for background, we were really interested in understanding what's happening with the quality of decisions for elective surgical procedures. We were focusing on 4 orthopedic procedures: a total hip replacement, total knee replacement, and then spine surgery for folks who had lumbar herniated disc or lumbar spinal stenosis. And this is because, osteoarthritis and low back pain really are leading causes of disability for older adults, and surgery is one of the common treatments for them. There are certainly also non-surgical options for these conditions, but surgery is very commonly done. Clinical guidelines do recommend shared decision-making for deciding whether or not to have the procedure. Again, they are elective, which means there's no reason you have to do this. It's really a matter of, are your symptoms bothersome enough that it's really getting in the way of living the life that you would like to lead? And then are the risks of surgery and the potential complications worrisome enough, and how do you make those trade-offs? So the clinical guidelines do recognize the importance of shared decision-making for selecting treatment. However, the extent to which this happens in routine care isn't known. So the purpose of this study was to measure the quality of elective surgical decisions for these 4 different types of surgeries across 4 hospitals that are part of Partners Healthcare System. So just to give a sense of the setting, so we worked pretty closely with Partners Healthcare. This is sort of the administrative Uber organization that houses, I think, at least 7 to 9 hospitals, maybe 300 to 400 primary care practices, sort of a very large conglomerate of healthcare. We worked closely with the Neurosurgery and Orthopedic Quality, Safety, and Value Collaborative. And this is a group that is comprised of all of the orthopedic surgery chiefs, some of the more service line chiefs, and other surgeons across all of the different sites. And so this is sort of the clinical group trying to figure out, how do we really improve the quality of care? So they were very instrumental in helping us with this project. We looked at 4 sites. 2 were academic medical centers, 2 were community hospitals. And we also have had a patient advisory committee involved in this work to help us think about, how do we think about measuring the decision, the quality of these decisions, how do we communicate this information, how would they interpret this information if they heard about this kinds of things with their surgeon, would that make them more or less likely to go to a surgeon? So these are the groups that were really helping us think about putting this into practice. So for the protocol, the methods, this was a mailed survey. For most of these conditions, with the exception of herniated disc, this is an older patient population, and we found that a mailed survey has pretty good response rates. So we looked at patients who were having a primary hip or knee replacement for osteoarthritis, or surgery for lumbar herniated disc or lumbar spinal stenosis. So we looked at patients who had surgery between January 2018 and June 2018, and then we selected a subset of those patients to survey. We tried to get balance across the different conditions as well as across the different sites. And we surveyed patients about 4 to 6 months post-operatively. We did provide a $2 incentive with the survey, and then we made reminder calls and did a reminder mailing to try and improve our response rates. So the 2 measures we focused on, we were looking at the shared decision-making process survey. So this is a short 4-item measure. And we looked at whether the patients reported that they talked about non-surgical options with their healthcare team, pros and cons of surgery, and did they talk about their preferences. So scores range from 0 to 4, and then higher scores indicate more shared decision-making happening. We also looked at a measure that's derived from decision quality instruments, and it's called the Informed Patient-Centered Decision. And so the decision quality instruments have knowledge questions, and they're specific to each of the different conditions. And so we looked at a total knowledge score, so patients who had a passing knowledge score on these, as well as a clear preference for surgery. And so we did ask patients, it was post-operatively, but we did ask them, what did you want to do to treat your knee pain or your hip pain or your back? And they could choose, I wanted to have surgery, I wanted non-surgical options, or I was not sure. And both of these measures have been NQF endorsed for use in accountability and payment programs. And so we were following the protocol as set out in the endorsement. So for analysis, the key questions we were looking at, first, just are there differences between sites and surgeons or conditions in shared decision-making in the scores and in the rates of the IPC decisions? So all the analyses we'll be presenting are regression analyses that controlled for clustering of patients within the surgeons. And we examined factors that were predictive or associated with these, site, gender, age, race, and then condition. So in terms of the sample characteristics, so we ended up getting about 646 responses back from patients. It was about a 74% response rate. Our non-responders were a little bit older. Our responders tended to be a little bit older and have higher education than our non-responders, but no other factors were associated with response rates. And then the age, we got more hip and knee patients. There's just a lot more hip and knee surgeries done than spine surgeries. And the spine patients were a little bit younger, a little more likely to be male. Very few patients received a decision aid as part of their care, even though they were accessible to all of the patients and clinicians. We can talk about maybe why that happened a little later. And then the number of surgeons, we had 37 surgeons across these sites. There are 7 surgeons that actually practiced at multiple sites, so we can talk about that too if you want. Okay, so results. So shared decision-making process scores. So what we did was collapse the 2 spine together because they seem to kind of really track together, and then the hip and knee together, and they seem to track very well together. So overall, there was a big difference in scores from the spine to the hip and knee. So it seemed pretty consistently that our spine surgeons are actually much more likely to discuss non-surgical options and much more likely to discuss the reasons not to have surgery with their patients compared to our hip and knee surgeons. And when we look at it at the surgeon level, so this, it's not any kind of word at the bottom, it's just if I gave every surgeon a letter, not a number. And so we had 22 surgeons who had at least 15 patients in the sample, so we restricted this to just those 22 surgeons to kind of compare rates to see what kind of variability there is across the system. So the overall mean was 2.8, and you can see the green here are our hip and knee surgeons, and the yellow are the spine surgeons. And so with that one outlier hip and knee surgeon who does a good job, we're going to observe him or her and figure that out. But pretty much it tracks that, actually all of the spine surgeons seem to be having different conversations than our hip and knee surgeons here. And the scores range from 2.3 to 3.1 for hip and knee, and from 2.8 to 3.6 for our spine. So even within, there's a pretty big, some big variability. So when we look at factors associated with the shared decision-making scores, the scores are lower for hip and knee. They decreased with increasing age, and then the hospital, sex, race were not predictive of the scores. And so here's a little bit of a different story. So we looked at the rates of informed patient-centered decisions, and here the hip and knee docs are looking a lot better. So 69% of their patients met the criteria compared to 40% of our spine patients. And what I'll do is break that down a little bit because that variable is obviously the knowledge plus the clear preference. So let's look at the knowledge scores, and it's clearly tracking that the knowledge scores are much higher for the hip and knee. These are decision-specific knowledge scores, so part of it might be just the difficulty of the test. It's not necessarily well calibrated across conditions, but it's also clear that there's just a lot of gaps in what our spine patients understand. And if you look at the surgeon level, so here again, there's pretty wide variability, but all of the hip and knee surgeons in green are doing a lot better than our spine surgeons on these. And we look at a percentage with a clear preference for surgery. So we've got, again, more patients who had hip and knee surgery having a clear preference than patients who had spine surgery. And this is all these patients did have surgery, just to make that clear. So this was their post-operative assessment of their preference. And when we look at that, there's still some variability here. For spine, it ranged actually from 44% to 78%, basically. And then for hip and knee, it was 70 to 94%. And so overall factors associated with the IPC decision. So certainly more likely, the condition was a big factor, more likely for hip and knee patients, more likely for males, more likely for white patients, and less likely with increasing age. And then hospital was not predictive. So in summary, overall, the scores indicate a lot of room for improvement for elective surgery decisions. There are gaps in decision quality that we identified, particularly for older patients, female patients, and then non-white patients. And when we look at the hospital level, there was actually very little variability, but there was considerable variation among the surgeons and by condition. And so as we're thinking about this, thinking about strategies to successfully implement shared decision-making into clinical practice are certainly going to depend on the specific disease. The things that we're going to do in the spine population, it's going to be much more focused on trying to figure out how do we effectively communicate the information, and maybe even a little less on the physicians who seem to be, at least from their patient report, doing a little more shared decision-making. On the flip side, for the hip and knee, we might have to do a little more focus on the training of the clinicians. There are clearly some limitations of the study. And then in terms of where we're taking this next, we really want to examine, we're actually feeding all of this information back to the surgeons and the chiefs. We've presented it to the Orthopedic Collaborative and examining whether that kind of feedback will stimulate people to think about and improve, maybe use decision aids more or other issues. And then we're also going to be monitoring the scores. So the collaborative decided to take 10 of those items and incorporate it into our patient-reported outcomes registry. So these are now being collected on all patients who have surgery. And so we're just trying to figure out how to understand that data and then use that to kind of do monitoring over time. So in conclusion, we definitely had some deficits in the quality of decisions for common procedures. And then routine measurement really is critical to help us understand these and hopefully, ideally, and maybe next year we'll be here talking about how that might prompt improvements. Thank you.
Thank you very much. This presentation is open for questions. I have, someone's coming up to ask a question. I also have a question, but you go first.
Joanna Hart from University of Pennsylvania. That was fantastic. You know, it's interesting because I had sort of a different take on what was happening. And I'm curious to see how you're going to tease apart the idea that people rated the shared decision-making process higher when they were sort of less well-informed, and they also had a stronger preference for surgery. And so is that really showing us instead that people didn't really want to be sort of an informed consumer about these surgeries, and they kind of wanted someone to give them a recommendation and therefore left with sort of high process marks, even though they didn't really know anything?
So it's interesting, and it's not 100% clear where it might fall out, but there really are differences between the spine surgery and the hip and knee surgery in terms of there's more uncertainty with spine surgery. I think the spine surgeons don't sell it quite as hard as our hip and knee surgeons do. So I do think it's actually reflecting that the spine surgeons are providing a little more like, well, there's some downsides. Maybe the information isn't getting communicated in a way that's helping the knowledge of our patients. But you know, the story that the hip and knee surgeons are kind of showing are that it's, you know, the surgery is really effective and it does work pretty well. I think another thing is just that the knowledge questions don't necessarily translate. They're just harder for the spine than the hip and knee. So it's also trying to tease that out. But you are right. There's not an inverse relationship. because we looked within each and looked at the relationship between the shared decision-making process scores and that IPC. And there was actually just no relationship. So we're trying to understand, what's going on with that, because it was a little bit of a surprise for us how different it was.
Another question. This will be the last question.
Thank you, Karen. Susanna Miyoshiga, University of Massachusetts. As you know, I have a lot of interest in high-risk decisions. So spine surgery to me is a lot more high risk than a knee replacement. Could that have a factor? Or be a factor?
I think it might be. I mean, you know, I think the surgeons were kind of wrestling with this when we were trying to talk about what's going on. And they, you know, I think they did recognize, just what we were mentioning, that it's a different kind of conversation that they have. And they're sometimes trying to talk people out of surgery as opposed to just, you know, yep, you've got the surgery, let's go and do it. So, yeah, I don't know. We'll need to figure out how to tease that out more. But I think that definitely could be a possibility. Did you have a question? Or you good?
I will talk to you afterwards.
Okay, thank you.
All right. Next, we have Cara McDermott, who's going to be speaking about barriers to goal concordant care at the end of life, findings from interviews with caregivers of patients with cancer.
We'll find out in a second. Okay, fantastic.
Hello, everybody. I'll be speaking today about a qualitative study that I completed as part of an Academy Health New Investigator Small Grant Award, Barriers to Goal Concordant Care at End of Life. With respect to conflicts of interest, I and the other authors have no conflicts of interest to report. This study was funded by a combination of the Academy Health New Investigator Small Grant Award and NIH funding for salary support. The purpose of this study was to understand caregiver perspectives of barriers to goal concordant care at end of life. And for here, we talked about goal concordant care as eliciting and acting on patient and caregiver values and preferences regarding anti-cancer therapies. So before I go on, I'm going to talk briefly about goals of care immunotherapy and anti-cancer therapy at end of life. So first, goals of care conversations establish patient preferences and priorities for care and quality of life. They ideally would be incorporated throughout healthcare, but especially when there's a life-limiting illness or potentially life-altering or life-limiting treatment. Although patients may have documented goals of care, such goals may not be known by clinicians. They may not even be known by family members if, for example, it was something that was filled out as part of estate planning many years ago. In addition to goals of care being necessary to understand why a patient and family member may have certain motivations for care, anti-cancer therapies at end of life are common. So with respect to traditional chemotherapy, and in this context, I'm talking about intravenous chemotherapy or oral anti-cancer agents that are targeted to a specific molecule. Chemotherapy in the last month of life, depending on the type of cancer and the setting where care is received, 6 to 50% of patients receive chemotherapy in the last 30 days. 1 to 24% receive it in the last 14 days of life. Now, chemotherapy received at end of life is associated with emergency department visits, for example, for hydration, fever, ICU admission, and in-hospital death, as well as reduced patient quality of life. And some of these outcomes for patients, such as ED visits, ICU, and in-hospital death, have been associated with increased psychological distress and complicated grief for surviving caregivers. Now, immunotherapy in the last month of life has been associated with poor performance status, lower hospice enrollment, and in-hospital death as well. Immunotherapy is fairly new on the anti-cancer therapy scene. From 2011 to 2018, 6 immune checkpoint drugs have been approved for 14 indications. And the estimate is that up to 43% of patients with cancer may be eligible to receive immunotherapy. However, of those receiving immunotherapy, an estimated 12% actually respond. And I note this graphic here with understanding immunotherapy side effects. So approximately 5% of patients will have severe side effects requiring hospitalization or may result in death, such as encephalitis or pneumonitis. And then 30 to 50% typically have mild to moderate side effects, such that if it's grade 2 or grade 1, they may continue with immunotherapy should they recover from the side effects. Now, cancer care in the age of immunotherapy is complicated. Immunotherapy is viewed as a symbol of hope. There's high-profile positive anecdotes. In one study in Australia, patients receiving immunotherapy for melanoma, less than 10% understood the side effects and were able to accurately state the likely efficacy of these drugs for them. And some of you may have heard of the Jimmy Carter case, which he was diagnosed with metastatic melanoma at the age of 91. In August 2015, he said he had brain and liver metastases. And by December 2015, after receiving pembrolizumab, there was no evidence of disease. He's still alive at 95. And this is known as the Jimmy Carter effect, colloquially. And of interest in this study, 3 of the caregivers, or about 10%, specifically mentioned Jimmy Carter as a reason why they and their loved one wanted to receive therapy. So the purpose of this study was to understand caregiver perspectives of barriers to goal concordant care at end of life, again, with values and preferences regarding anti-cancer therapies. We conducted audio-recorded semi-structured phone interviews from October to December of 2017. Our participants were 35 adults who were primary caregivers for a family member who died with cancer between July and December of 2016. I conducted all of the interviews. I will state that in terms of positionality, I am a former cancer caregiver myself, a former social worker, and I'm trained as a geriatric oncology pharmacist in addition to being a researcher, which certainly informed some of the ways that I asked questions. We've specifically talked about goals of care. Were they documented? Were they known? Did they discuss these with the clinicians? And did the care received reflect their goals of care? And myself and my research analyst coded the transcripts using qualitative content analysis. In terms of demographics and characteristics, the patients were 30 to 88 years old at the time of death. Lung, breast, and pancreatic cancer were most common, along with hematologic malignancies. Caregivers ranged from 34 to 85 years old. 91% were white, 63% female, and 89% spouses. All patients had received at least one anti-cancer therapy. 4 major themes were noted as we analyzed the data. The first was misaligned values for care. This first quote, the doctors are saying, do another round of chemo, and she's saying, no, I know I'm going to die, and taking this drug that you're offering me is not going to help. This was a case of a mother sharing her daughter's experience with a rare cancer, and after receiving one round of chemotherapy, she decided that her quality of life was more important than trying to extend her life. However, her doctors were not receptive to that, telling her that she was young, she needed to continue on. When they were giving him chemo, they knew it wasn't doing any good and that we needed to talk to some more, but it was too late. And this was a situation with a family who continued to receive lines of chemotherapy for their loved one and approved them. When the patient expressed doubt, before they could then again talk to the oncologist to have another goals of care discussion, the patient fell into a coma and died. Clinical momentum. In this study, patients could have cancer for a long time. They could have had cancer, received treatment, and then relapsed or recurred, or received a cancer diagnosis and died rather quickly. But after 15 years of always choosing treatment, it was hard to change perspective and pattern. To clinicians, I would slow down and make it very, very clear to caregivers and patients that they're at a turning point. Hope for a cure. Hope was constant in all of these interviews. This first quote is from a woman whose husband was in the ICU, ventilated on pressor support. Maybe if I just would have left him on life support a little longer, maybe there would have been a miracle. And she had hoped that we could stabilize her husband long enough to receive pembrolizumab like Jimmy Carter, and that he would walk out of the ICU. As a family, we were grabbing at straws trying to help him. Again, this was a family and caregiver situation where they wanted to pursue clinical trials, alternative treatments in other countries, and felt that the oncologist was at odds with them, that they couldn't all get on the same page regarding what kind of care to deliver. And finally, decision-making with incomplete information. In hindsight, I wish she hadn't had that family chemotherapy, but the oncologist didn't warn us that it might be hard for her to tolerate. To healthcare providers, don't make a value judgment about what you should tell them and what you shouldn't. And this last quote comes from a woman whose husband received immunotherapy and unfortunately experienced devastating side effects. And what she said was that they believed that the immunotherapy was their last-ditch effort, and they didn't understand that for him, the chance of efficacy was actually much lower than the chance of experiencing a side effect. Now, how do we overcome these barriers? Well, the first is real-world evidence. We really don't have great real-world evidence right now on immunotherapy. We're giving this to older adults and people with multiple chronic conditions, not totally understanding how they may respond. I would also say decision aids. I'm not aware of an immunotherapy decision aid. If there is one in cancer, I know there's one in allergy and asthma, please let me know. But unfortunately, for some patients, we're at equipoise because we don't have enough data to tell them what might happen. For others, there's a clear indication for immunotherapy based on molecular profile and how they're performing. Embedded palliative care. So there is one center in Boston that has embedded palliative care in their outpatient oncology clinic for folks who are getting immunotherapy and oral targeted agents. And that has helped in terms of hospice duration and quality of life for those patients. And finally, regularly reassessing goals of care. There are multiple twists and turns during the course of cancer treatment where prognosis may change, patient thoughts and patient condition may change, as well as caregiver availability. Finally, in conclusion, further research is needed on how to best communicate these risks and potential benefits of anti-cancer therapies in the context of informed goals, especially in the age of immunotherapy, so patients and families can make informed decisions aligned with values and goals throughout treatment. So I want to say my thanks and gratitude to the bereaved caregivers who participated in this study, my research mentors and funding. For any questions, please feel free to contact me on Twitter or email, and those are references. So happy to take any questions.
Do we have any questions? We have time.
I'm Dan Kabuka from University of Ottawa. One thing that jumped out with a few of those quotes was burden of decision-making that fell heavily on the families. It felt very responsible, or on the doctor. The doctor said we have to do this. I'm just wondering if you could, did that come out as a theme more? Could you comment more on how decisions fell on one side or the other?
Absolutely, and really in this, it was really a model of shared decision-making where it was the triple talk, more of a triple talk model where we have the patient, the caregiver, and the oncologist, and things would ebb and flow and go back and forth. In terms of the caregiver involvement, this typically ramped up as death approached and the patient was no longer able to share their thoughts on things. What was interesting that we found throughout the data as well, which is not data I'm presenting here but have presented elsewhere, is that many caregivers, as death approached, started to shift towards wanting more aggressive therapy because they did not want their loved one to die, or expressing more concerns that the therapy was not what they had wanted and that they had exceeded what they thought was feasible and fair for their family. Family burden did come up a lot in terms of decision making. A separate part that I have presented elsewhere is actually around financial toxicity and how financial burden started to influence caregiving decisions and treatment decisions as death approached, especially with respect to immunotherapy and clinical trials, that many people did experience significant financial burden in this study. For the oncologist, they really wanted the oncologist to take the lead at first, but that was more so for older participants. So what I did find was that for patients who are over 65 and older caregivers, they wanted the oncologist to take the lead and to guide them through decision-making. Adult children were also significant influencers there. But for younger adults, they really wanted aggressive treatment as much as possible. They talked about going on the internet, and a large motivation for that were people with dependent children, that they wanted to live to see their children at least make it to 18. So that was some of the factors that we found around what shaped decision-making through the process.
Thank you.
Thank you.
Our next speaker is Semra is coming back up. Semra Ozdemir. And yes, and she's speaking now on patient preferences for second-line medications to manage type 2 diabetes mellitus.
Okay, great. Hi again. Well, this study was funded by AstraZeneca Singapore. Otherwise, I have me and my authors don't have declared no conflicts of interest. So I'm going to talk about a preference-sensitive decision. So preference-sensitive decision is usually happens when there isn't a dominant treatment option that's better than the other options, or there isn't a clear treatment option that's better than the others. So in this case, I will be talking about treatment options for type 2 diabetes patients, which are SGLT2 inhibitors and DPP4 inhibitors. So these inhibitors are usually used second-line treatment, but sometimes they can be used also as first-line treatments. So these inhibitors, both SGLT2 and DPP4, they have similar glycemic control. So in terms of main outcome, they're similar. However, they differ in terms of other outcomes. For example, SGLT2 inhibitors provide some weight loss. I don't want to say just benefits, because weight loss might be something some patients might be interested in and some patients may not. But also it has cardiovascular benefits. However, they have also higher risk of UGTI, urinary and genital tract infection. On the other hand, DPP4 inhibitors, they're weight neutral. They don't really affect on weight. They don't have any additional cardiovascular benefits and no additional risk of UGTI. So it's really about, how patients, in this case, as you see, there isn't one clear treatment option, treatment better than the other in all aspects. So it's really about patient preferences. So in this case, we investigate patient preferences, and specifically we're interested in quantifying how much patients are willing to take UGTI risk in exchange for benefits in other outcomes. So we recruited patients at the diabetes clinics in Singapore General Hospital and also via newspaper advertisements. So we recruited adult patients who are diagnosed with type 2 diabetes who are not on either of these inhibitors. Also, we recruited patients who didn't have any kidney problems or were not pregnant. So we used a survey method called Discrete-Choice experiments. which allow us to quantify the relative importance of attributes based on the attributes and levels used in the study, as well as quantifying, for example, you can quantify willingness to pay or maximum acceptable risk, which is the one we did in this case. We also collected data on patient characteristics. So here's an example question. If you have never seen a DCE question before, I always use the analogy of buying a house. Actually, after moving to Singapore, I started using the example of renting a house. Buying a house is not possible. So, you know, when you're renting or buying a house, you start thinking about several attributes, several factors, right? Number of bathrooms, number of bedrooms, the commute to your work, school. If you have children, you think about, you know, schools in the neighborhood, maybe other, you know, crime factor if you're living in a city with those problems. So basically, you think about, there are several factors that influence your decision. And then you think, you start comparing, you know, oh, this house is great, it's big enough for us, but the rent is so expensive. On the other hand, the other house, the rent is reasonable, but it's far from, you know, the commute is gonna be longer. So there's so many factors you start trading off. So DCEs are very, very similar. So they mimic real life decision making. So what we do, we present hypothetical treatment options, in this case, treatment A, medication A and B, and we identified attributes that we think influence the decision-making process. In this case, after literature review, expert interviews, and patient interviews, we identified 6 attributes. Years that the medication will be effective, weight loss in the first year of starting medication, UGTI risk, risk of mortality, risk of hospitalization from heart conditions, and of course, out-of-pocket cost in per month. So we show 2 treatments at a time and ask patients to choose which one they prefer. And each patient were shown 10 of these questions. So each time the levels of these attributes change, so they saw different types of hypothetical treatments. So we also, one of these 10 questions included a question that tested the attention. Basically, one of the treatment medication was better in all attributes than the other treatment, so you would expect that everybody who's maximizing utility should choose that medication. And we also trained the respondents what we mean in terms of by these attributes, as well as how to interpret risk. So we use latent class logit model to investigate, to analyze the DCE data. And we wanted to see whether there are different groups of patients with different preferences and who are likely to be in these groups. And for each group, we calculated the relative importance of each medication attribute relative to the other attributes used in the study. We then calculated the willingness to accept UGTI risk in return for benefits associated with SGLT2 inhibitors. So in total, we recruited 159 patients. 12 patients failed the attention test question that I mentioned to you earlier, and we're creating noise, so we excluded those patients from subsequent analysis. So the final sample size was 147, and most of these patients were recruited from the clinics. So here's the patient profiles. So 40% were diagnosed a year or less ago with type 2 diabetes. 80% changed their medication in the past 2 years. So 1/3 of them experienced UGTI risk in the past, half of them had bad experience, and 20% had heart problems in the past. So after trying different classes of latent class, from 2 to 4 different classes, we ended up choosing the 2 class latent class. And we classified, we labeled these groups based on their preferences, which I'm going to show you later. So the first group, we labeled them as survival conscious, and the second group as UGTI and cost conscious. So the split of the sample was about half off. So let me show you the relative attribute importance by each class. So these are the findings from the survival conscious group. The reason we called survival conscious, as you can see, the most important attribute was the risk of mortality. Actually, this group was in general very risk averse because the risk of the other most important attributes were risk of hospitalization and risk of UGTI. And as you can see, cost was not important to this group within the range of the cost levels used in this study. And so the way relative attribute importance works is actually these are out of 100. So I could have shown it as a pie chart, but I wanted to be able to compare between the two groups, and this ended up being a better way to present. So the other group is, we call them the cost UGTI conscious group. As you can see, cost was the most important all the way down. You can see on the left or your right. Cost was the most important attribute, followed closely by risk of UGTI. So we looked at who are likely to be in these groups. So for patients with prior diagnosis of cardiovascular issues, we're more likely to be in the survival conscious group, which is not surprising. And patients who have lower income were more likely to be in the cost conscious group. And patients who changed medication dosage in the fit and the last year was more likely to be in this group as well, because this was more, again, this attribute was more important to this group than the other. So I'm going to show you now willingness to accept UGTI risk in exchange for reductions in mortality risk and hospitalization risk, as well as increase in years of medication effectiveness. I'm not showing for weight loss because what we noticed was they were not significant. So as you can see, so I'm showing it for different group, two different groups, as well as the weighted average for the full sample, the willingness to accept UGTI risk. So in general, willingness to accept UGTI risk was higher for the survival conscious group for reductions in mortality risk and hospitalization risk, because as you remember, if you remember, these were the most important attributes for this group. And on the other hand, for increasing the years of medication effectiveness, cost conscious or UGTI conscious group was willing to take risk. So in conclusion, these are great methods in terms of being able to quantify preferences and quantify measures like willingness to accept risk. And we can see that there were clearly distinct two groups of patients with different preferences, and medical history and economic status actually were significant predictors of this grouping. And patients in the survival conscious group were more willing to take substantial UGTI risk for benefits in other outcomes, versus patients in the UGTI and cost conscious group were not. Based on these results, you can see that patients have different preferences. So our recommendation is, which probably you have heard all day long, and even if you were here yesterday as well, that physicians should discuss the benefits and risks about each treatment option with their patients and incorporate patient preferences into the decision-making process. Thank you.
This presentation is open for questions. So I have a question while we're waiting. So I thought it was really interesting the way you did latent class analysis, and then you have these two groups of people living with type 2 diabetes. And I'm curious about your thoughts about when we do those latent class analyses, does it run the risk of contributing to essentialism, where a physician might have someone in front of them, so a person living with type 2 diabetes, in front of them who has lower income, and the physician thinks, oh, well, this person is one of that group that they're not even going to be interested, so I'm not even going to raise this medication as a topic of discussion. What do you think about that?
It's a very good point, and you can see these are very crude estimates if you think about it, and it's really based on only 150 patients. So for making really that kind of generalization or far reaching out to individual level, it's better to do, I wouldn't go and recommend using these at this point, but it's a good way to look. On average, there are two groups of patients, but I wouldn't go recommend, say, saying, okay, you're coming from lower income, you should be in this group. I don't think that will be wise.
The group that failed the screener question and wasn't paying attention, were they different in terms of demographics? And you might hypothesize that with a diagnosis like diabetes, they're doing a worse job with self-care. So it might be an interesting group. I know you excluded them from this analysis, but they might be somebody to pursue pretty actively because they probably could benefit in some other ways other than applying their preferences to their treatment.
That's a very good point. Thank you very much. So it wasn't really a screening question. So they went through the whole survey. And I didn't mention, but this was an in-person survey as well. So we had our interviewers conducting these surveys, and they were they went through the survey with the patients, and they were there to answer any questions. But of course, it's possible. So we couldn't really do a quantitative test of comparing these two groups because we had only 12 patients who failed the test. But if we had large numbers, it would have been easy to do that comparison. Definitely. Yeah.
One more question.
Thank you for your presentation. In the beginning of your presentation, you talked about the different classes of medications. I was wondering how your patient preference results translated to those medications in terms of patient acceptance of those medications, given the specific risk with those medications.
Yeah, actually, we looked at that too, but I had only 10 minutes to talk about that, to present the main findings. But definitely, that's the flexibility of DCE methods that you can really, as long as you have the features of the medications, you can really map up, pulling those features from your design and map up to the treatment. Yeah. And we were able to do that. Specific. And for this one, actually, most patients, the uptake of SGLT was very high.
Okay.
I can't remember the exact number, but something around over 80%.
I was kind of curious if those two groupings of patients, maybe some of those patients would fall out of the acceptance of one of the medications while another would accept that medication.
And definitely the uptake was quite different between the two groups.
Okay.
Yeah.
Thank you.
Yeah. Thank you.
Thank you very much. Next, we have Nancy Schoenborn talking about diabetes guideline frameworks for individualizing glycemic targets. What do patients think?
Thank you, everyone, for this opportunity to share this project with you. I have no conflict of interest, but want to appreciate the funders that supported this project. So thinking about optimal treatment target for type 2 diabetes in older adults, it's really uncertain. We know that the benefit from intensive aggressive glycemic control is often delayed for many years, while the risks of such approach, such as hypoglycemia, polypharmacy, and treatment burden occur immediately. Because of this, clinical practice guidelines have increasingly recommended an individualized approach to setting the treatment targets. This is one example of such an guideline from the American Diabetes Association. On your left, you see that the guideline recommends the consideration of specific patient factors. And then on the right, you'll see that each factor is intended to have a directional effect. So for example, for disease duration, it's recommended that someone who has long-standing diabetes have a less stringent treatment target than someone who has newly diagnosed disease. Despite these guidelines, national studies have shown that intensive control and potentially over-treatment of type 2 diabetes is still common in older adults. And our question is really to want to look at how older adults perceive these guideline factors that's used to individualize and determine treatment target, which as far as we knew was not known, with the thought that any mismatch in patient understanding or in their priorities can make it difficult to engage in shared decision-making and potentially contribute to over-treatment. So these were our study questions. Do older patients with type 2 diabetes consider these guideline factors important? And whether that differed, whether they're deciding to add a medicine versus whether they're trying to stop a medicine. And then lastly, we were interested to see how patients perceived the relationship between each factor and treatment intensity and whether it was the same as what the guideline recommended. So we conducted a cross-sectional survey using an existing online survey panel. Knowledge Panel is the largest national online panel that uses probability-based sampling as opposed to using volunteers. And they have over 55,000 members representing the US adult population. We included adults 65 and older who self-reported to have type 2 diabetes. There were two modules in the survey. The first one explored the importance of these 7 factors. We chose these after a review of the major clinical practice guidelines. And we randomized the participants to either a scenario trying to decide whether or not to add a medicine in someone who has a borderline high A1C, which is a routine measure of glycemic control, versus a second scenario, whether or not they're deciding to stop a medicine in someone who has a low A1C. And to reflect the directional effect of each factor in the guidelines, we phrased each factor differently depending on the scenario. For example, in the decision about adding a medicine, we asked whether someone having had diabetes for a short time is a good reason for adding a medicine, versus we asked whether having had diabetes for a long time is a good reason to stop a medicine. We asked that binary question, so yes, no, is it a good reason? And we also used the method of best-worst scaling to assess the relative importance among the factors. This is an example of a best-worst scaling choice task where we presented a subset of the factors and asked the participant to choose the one that's the best and one worst among the 4, and we systematically vary which ones we presented in the choice tasks. This method allowed us not to only get at a ranking, but to quantify how much more preferred is one than the other. Then Module 2 assessed that perceived relationship between a factor and treatment intensity. So focusing on 5 of the 7, we presented 2 hypothetical patients, such as here, looking at treatment, disease duration, and asked who should be treated more aggressively. And so we pilot tested the survey and iteratively revised it based on older adults' feedback in terms of clarity, and collected the data from December of last year to January. So 818 older adults completed the survey with an average age of 74 years old. Slightly over half were male and about 2/3 were of Caucasian race. There's a fairly even spread from time since diabetes diagnosis. Over half reported their most recent A1C was under 7, and about 2/3 self-reported their goal A1C was supposed to be under 7. And even though majority reported that they would be willing to stop a diabetes medicine, relatively few mentioned that their doctor has recommended this to them. This is a result from that binary question asking whether each of these factors is a good reason to add or to stop a medicine for diabetes. And you can see on the left, when they're deciding about adding a medicine, many thought these factors were important. But for each of those factors, they're consistently found to be less important when they're deciding to stop medicine. What I mean by that is that although the majority thought having had diabetes for a short time was a good reason to add a medicine, very few thought having had diabetes for a long time was a good reason to stop medicine. In fact, almost half thought none of these were good reasons to stop medicines. This slide showed the best worst scaling results where we conducted a conditional logistic regression to get at the relative importance of each of these, which then rescaled on a ratio scale. And so they'll all add up to 100, with 0 being completely not important and 100 being important at the expense of everything else. So here you see for both of the scenarios, concern over the risk of side effects was the most important, while concerns over treatment cost or effort were lower on the priority list. This is the result about the perceived relationship between each factor and treatment intensity. And you see that with the top 3 of the 5 factors, what most of the participants chose was actually opposite of the guideline recommendations. And so most of the participants thought that people who had longer disease duration, who already have severe diabetes complications and who already have many other health conditions should actually be treated more aggressively for diabetes, which is the opposite of what guidelines recommend. Their perception was consistent regarding life expectancy and risk of side effects. The limitations of the study included that we did use hypothetical scenarios. We only focused on a selected number of factors and did not examine others that may be relevant. The responses could have been sensitive to how we worded the factors. And although the online panel is supposedly nationally representative, there could be subgroups that are not well represented. So in conclusion, we found that older adults with type 2 diabetes considered guideline factors more important in the decision to add a medicine than the decision to stop medicines. And concern about side effects was the most important in both. And that their beliefs about how these factors related to treatment intensity were often the opposite of guideline recommendations. And so some of the takeaways for us is that this really suggested perhaps starting versus stopping medicines are not merely mirror reverses of each other, but rather distinct decision-making processes. And we really don't have a good understanding of what are important to older adults when deciding to stop diabetes medicine, since almost half didn't think any of these were important. And so really needing further study. In terms of how their perception was really opposite the guidelines, I think that showed the rationale behind this individualized approach may not be intuitive to patients. And we could not really distinguish whether that was a lack of awareness requiring more education, or even if they understood the rationale, they would still disagree. But I think either way, it really shows that on the part of the clinicians, better communications to engage patients and elicit their perspectives are essential. So thank you.
Questions?
Hi, Nancy Lee Simmons from Mass General. Thank you so much. This is great. A question that came from me here was administering that same hypothetical scenarios to physicians, and what answers would you get? I wouldn't be surprised if the guidelines aren't intuitive to many physicians as well. And I bring this up because for so many of my older patients with diabetes, they've heard from another clinician that their A1C is too high, and they're 83 and their A1C is 7.8, and I'm thrilled. In fact, I've told them that rule of dividing their age by 10, and they kind of laugh and they don't believe it, though they heard from somebody else, their ophthalmologist or whomever, or from their results manager letter that says it's out of range. So it's just a question for future study, which is I feel like we're a strong influence for good or for bad, and I'm not sure we know how to.
I completely agree. I think patients definitely can get mixed messages, and sometimes that varies depending on the specialty of the physician they see. And I also share the same thought that perhaps the guidelines are not well disseminated even among the clinicians. So that's really interesting suggestion to administer the same survey to doctors. Thank you.
Hi, Nancy. Thank you for a great talk. I'm Jesse Jans from Maastricht University. I was just wondering about the difference between adding versus stopping, and whether you considered adding a third category, not adding, which is different from adding, if you know what I mean, and what your hypothesis would be around the scores.
Yeah, no, that's a great question. And that's something, we can think about in a future study. So it wasn't something we specifically consider, but I agree, I think from clinical experience, whether to decide not to do something, it perhaps is not as deliberately discussed. I don't know that clinicians are as motivated to talk about not doing something, but it's certainly, I think it's a consideration I think about for my patients, and definitely thank you for that suggestion.
Hi, Brian Zickman-Fisher from University of Michigan. Could you go back a couple slides to the last table that had the discordant? Yes, that one. So what strikes me of the top three, the ones that you have noted are discordant to the guideline, is that in each case, the majority of participants are focusing on the person who has, in some sense, the greater disease, greater in time, greater in intensity, greater in terms of more things going on, et cetera, which suggests some sort of simplistic model of more disease means more treatment. And I'm just wondering if you have any other information or could think about ways of exploring this. Because if that's true, that people have a sort of simplistic mental model of, look, longer, more equals more treatment, that ought to generalize not just in this context, but to many other contexts that we might be very interested in.
Yeah, no, that's a great comment. I think the limitation of the study was that we couldn't go back and ask, why did you choose it? But I would say during the pilot testing, we found some, even though we weren't collecting data, we did get the same response. And I think some of where we did ask why, and it was about, well, they already have a lot of complications, more is at stake. We don't want any more bad things to happen to them. They already have so many other things to worry about. We don't want this to be yet another issue, so we should be more aggressive. And so thank you for, I do think this theme and framework could be very relevant to many other decisions as well. Thank you.
I'm just going to ask a quick clarifying question and then we'll stop. Did the people in your pilot testing, did they have type 2 diabetes?
They did.
Okay, thank you.
And next we have Matthew Modes. Are prioritized healthcare goals of seriously ill outpatients accurately identified by their clinicians? Great question.
Okay, hi, thanks for having me. So that's my title of my talk. I have no conflicts of interest and none of my co-investigators do either. So the primary focus of advanced care planning is shifting. In the old approach, patients were asked to make decisions about specific treatments like mechanical ventilation and CPR in advance. And the care that ultimately resulted, often in the ICU, reflected those treatment preferences without much respect to whether those treatments led to an acceptable quality of life for patients. For a variety of reasons, the approach is shifting to a new model where patients' values and goals are ascertained, and clinicians try to prepare patients and families to make medical decisions in the moment that are most consistent with the patient's values and goals, so that the care that's delivered is goal-concordant care across the spectrum of care, from outpatient to inpatient to ICU setting. Along the path starting from patients' values and goals to delivering goal-concordant care, there's intermediate steps. And in particular, patients and clinicians need to be on the same page about a patient's values and goals. If clinicians don't understand patients' values and goals, then it's going to be more challenging to deliver goal concordant care. So our goal with this study was to investigate 2 research questions among outpatients with serious illness for whom it would be appropriate to have a discussion with their clinician about their goals of care. First, we were curious what proportion of patients with a prioritized healthcare goal have that goal accurately identified. And second, we were interested in examining what factors are associated with patients whose goals are accurately identified. And in particular, we were interested in patient and clinician level factors and communication processes. So our study is a secondary analysis using data from a cluster randomized trial of a jumpstart form that was designed to improve goals of care conversations. In the randomized trial design, it started with recruiting 132 clinicians who were physicians or nurse practitioners who practiced primary or specialty care. Clinicians also had to have a minimum of 5 patients in their patient panel who were eligible. Recruitment occurred at 2 large healthcare systems in the Pacific Northwest, and randomization occurred at the level of the clinician. Using the electronic health record and the clinic schedule, study staff identified consecutive patients who were being cared for by the participating clinicians. And patients had to be 18 years of age or older, have at least 2 or more clinic visits with the participating clinician in the last 18 months, and then also have at least one of the qualifying conditions listed here. These qualifying conditions were selected to identify seriously ill patients with a median survival of approximately 2 years, or for whom a goals of care discussion would be appropriate. So 537 patients were enrolled. The intervention was a jumpstart form designed to improve goals of care conversations and was delivered prior to a clinic visit. So 228 patients received the jumpstart intervention and then attended the subsequent clinic visit, and 266 patients in the control group attended the clinic visit. Getting to our sample, after the clinic visit, both clinicians and patients were surveyed. So clinicians were surveyed within a couple days, patients within a couple weeks, and the data from these surveys is what we use in this secondary analysis. So 399 surveys were completed by patients after the clinic visit. And patients were asked this question in their survey, which is developed in the support study and is used to assess a patient's prioritized healthcare goal. And it reads, if you had to make a choice at this time, would you prefer a plan of medical care that focuses on extending life as much as possible, even if it means having more pain and discomfort? Or would you want a plan of medical care that focuses on relieving pain and discomfort as much as possible, even if that means not living as long? And patients could select either of those 2 options, or they could choose unsure. On the clinician survey, we asked a very similar question. It was slightly rephrased so that it said, if this patient had to make a choice at this time, it is your understanding that he would prefer a plan of medical care with the same options. So back to our study sample, we had 399 surveys were completed by patients after the clinic visit. 382 of those patients answered the question you just saw. And 338 also had their clinician answer the question. So that left us with 338 instances where we could compare the patient response and the clinician response to the question about prioritized healthcare goals. And I'll show you some descriptive statistics on this sample in a moment. For our research question, we were interested in accuracy, and because of that, we felt it was perhaps a bit unfair to expect clinicians to identify the goals of patients who were unsure of their prioritized goal. And so we narrowed our sample to patients with a prioritized healthcare goal, and that left us with 252 patients for our primary analysis. So for our primary analysis using our analytic sample, we defined our outcome as accurate or inaccurate using this coding scheme. So if both patient and clinician selected relief of pain and discomfort, or if both patient and clinician selected extending life, we considered that to be accurate. And any other combination we felt was inaccurate. Based on our sample size, we selected 9 exposures that included patient characteristics, clinician characteristics, and communication processes. We determined stability of prioritized healthcare goal by comparing patient enrollment surveys with patient surveys that were done after the clinic visit. The question you saw was asked at both time points. And then we determined whether a discussion about goals of care occurred at that visit by asking clinicians on their survey. So to estimate the proportion of patients with a prioritized healthcare goal that have their goal accurately identified by their clinician, we used a marginal intercept-only model with logit link and estimation with GEE. And to examine associations, we ran a multivariate marginal model with logit link and estimation with GEE. And these modeling strategies account for the fact that clinicians could have multiple patients enrolled in the study. So here are the characteristics from the 338 instances where we could match the patient response and the clinician response to that prioritized healthcare goals question. It was composed of 338 patients and 114 clinicians, because again, clinicians could have more than one patient enrolled. So patients were older, they were primarily white non-Hispanic, and the most common qualifying condition was a Charlson score greater than 6. Clinicians were middle-aged and they were primarily white non-Hispanic. The majority of patients prioritized relief of pain and discomfort, while about a quarter were unsure of their top priority. The largest proportion of clinician responses were that patients would prioritize relief of pain and discomfort, and fewer clinicians expressed uncertainty. So restricting to the 252 patients in our analytic sample who had a prioritized goal, 78% prioritized relief of pain and discomfort, while 22% prioritized extending life. And clinicians were spread among the 3 options within those 2 patient response categories. So for our first research question, we estimated 60% of patients with a prioritized healthcare goal had their goal accurately identified by their clinician. For our second research question, we assessed the following 9 exposures in a single multivariate model among the 252 patients with a prioritized healthcare goal. And first, here's just a table showing numbers and proportions in the inaccurate and accurate groups by exposure. And the accurate group appears to have a larger proportion of patients with stable goals and in whom clinicians reported occurrence of a discussion. In the multivariate model, we found 3 characteristics were significantly associated with patients whose clinicians were accurately identified their goals. And that was older age, patients who had stable goals, and instances when clinicians said a goals of care discussion occurred at that clinic visit. In addition, we identified 1 characteristic that trended towards our pre-specified significance level of 0.05, and that was if the prioritized goal was extending life as opposed to relief of pain and discomfort. Before I discuss the implications, I want to just highlight a couple limitations. First, patient and clinician responses were measured at slightly different times. Second, the question we used to assess patients' prioritized healthcare goal is probably oversimplifies complex thinking. This is sort of an emerging area of research of how to do this in seriously ill patients, and there's no perfect way to assess patient values and goals. Third, there may be some limits in generalizability based on sample characteristics, the fact this was in 1 geographic location, some non-response bias. And then fourth, I just want to highlight the importance of our finding of 25% of patients were unsure of their top priority, and I think a lot of work needs to be done to help patients construct health-related values and goals. Despite those limitations, I think there's some implications for our study. First, our finding that 60% of patients with a prioritized goal had their goal accurately identified suggests there's room for clinicians to improve their understanding of patients' goals. And I think better understanding of goals probably better positions patients to receive goal concordant care. Second, we found relatively weak associations, odd ratios around 2, but there's some findings. Communication between patients and clinicians about goals of care seems better as patients age. Goals are better identified when they're stable. Conversely, for patients whose goals change, it's going to be very challenging for the clinician to follow along without having repeated discussions. Fortunately, when discussions occur and when a clinician reports it occurs, there's better understanding, it seems, of goals. And then lastly, perhaps one of the interesting and potentially concerning findings is the suggestion that accuracy was better when patients' primary goal was extending life. And it's possible that this is because extending life is default care, but precisely because it's default care, the most important group of patients to be on the same page with clinicians is the group that prioritizes relief of pain and discomfort, because delivery of goal concordant care for them is going to require a shift away from default care. And so our findings suggest that clinicians may be more attuned to patients whose top priority is extending life as opposed to relief of discomfort, and that may have implications for goal concordant care. Our study is early work on health-related values and it's hypothesis generating. And in the future, I'm looking to explore how to best measure patient values and goals, find ways to improve clinician understanding of patient values and goals, and also to examine the relationship between clinician understanding of goals and patient receipt of goal concordant care. So I want to thank my mentorship team of Aaron Cross, Randy Curtis, and Ruth Engelberg, as well as my collaborators, Lynn, Lois, and Elizabeth, and thank my infrastructure support, which is the Cambia Palliative Care Center of Excellence, and that's my funding, and that this study was funded by PCORI, and in no way do the views that I expressed are those of PCORI. I'm required to say that by PCORI. Thank you.
All right. This is open for questions. And no, we're good. So we have about 4 minutes until the end of the time, even though our timer's out at the end. So Aisha.
Hi, I'm Aisha Langford from NYU School of Medicine. Nice presentation. I was just curious of your thoughts about, in the future, the best ways to kind of document these conversations. Just working with clinicians at NYU, my understanding is that the EHR has a million different fields. How people do notes vary a lot. You could put another thing in Epic that doctors are forced to fill out so that you have some formalized documentation of this. I'm just curious of if you had to design a way to do this where it's documented in a searchable way somewhere to follow these things.
That's a great question. I don't know the answer to it. I will say that I think having one place where everyone knows where it is really important so that people aren't looking in different places. I think right now, like you said, it's documented all over the place. I think in addition, with the same data set, after the clinic visit, we actually asked, we asked clinicians whether a discussion occurred, and then we also looked at the EHR to see whether they documented it. And I don't present it here, but there's a wide disparity there. That a lot of them are saying that a discussion occurred and there's no documentation to support that in their notes or anywhere else. So part of it is just getting documentation to happen, and then another part is figuring out a centralized location where everyone knows where it is.
Okay. I think we have time for one more question, and the person at the back was there first, so I'm going to let the person at the back go first. And there'll be time afterwards. Come talk.
Perfect. Thank you so much. That was a great presentation. Thank you so much. I just have two quick questions.
You have time for one question.
Very good. Very good. I have one quick question. I guess the intervention itself, was there any effect of the intervention? I don't believe you presented the difference between groups in the concordance and understand the patient's goals.
Yeah, we didn't look at that. We were most interested in whether occurrence of a discussion led to a difference or was associated with a difference. And part of the the intervention was designed to improve the occurrence of discussion. So we felt including them both in the model, there was just too much collinearity there, and so we needed to pick one. And after discussion with our biostatistician, she sort of felt, yeah, you can't interpret a model where both are there. So we were most interested in actually whether a discussion occurs and what the impact of that might be.
Thank you very much, and thank you for your kind attention to all our speakers. Let's thank all our speakers. And please do, if you didn't get a chance to ask a question that you want to